In this video, we will be covering varicose veins. Varicose veins or varicosities are abnormally dilated, tortuous superficial veins caused by incompetent venous valves. Varicosities may be small and harmless or large and bulging. Most commonly, this condition occurs in the lower extremities. They are often found in saphenous vein system, but it can occur elsewhere in the body, such as the esophagus. Primary varicose veins, also called idiopathic, due to a weakness of vein walls, are common in women. Secondary varicose veins result from direct injury or a previous venous thromboembolism or excessive vein distention. Secondary varicose veins may occur in the esophagus, vulva, spermatic cords, and anorectal area, and as abnormal arteriovenous connections. If the varicose veins are seen in esophagus, it is called esophageal varices. If it is in spermatic cords, it is called varicoceles. If it is anorectal area, it is called hemorrhoids. Congenital varicose veins result from chromosomal defects that cause abnormal development of the venous system. Reticular veins are smaller varicose veins that appear flat, less tortuous, and blue-green in color. Telangiectasias, often called spider veins, are small visible vessels, generally less than 1 mm in diameter, that appear bluish black, purple, or red in color. Varicose veins are rare before puberty. The causes of varicose veins are hereditary weakness of a vein wall or valves. A hereditary weakness of the vein wall may contribute to the development of varicosities, and it commonly occurs in several members of the same family. The condition is most common in people whose occupations require prolonged standing, such as salespersons, hairstylists, teachers, nurses, and ancillary medical personnel and construction workers. This condition causes long-standing distention of veins. Pregnancy may cause varicosities because of hormonal effects related to decreased venous outflow, increased pressure by the gravid uterus, and increased blood volume. People in advanced age, because of a loss of tissue elasticity, can cause varicose veins. The risk factors include family history of chronic venous disease, weak vein structure, female gender, tobacco use, increasing age, obesity, multiparity, history of venous thromboembolism, venous obstruction resulting from extrinsic pressure by tumors, thrombophilia, phlebitis, previous leg injury, and occupations that require prolonged standing or sitting. Now we will see the pathophysiology of varicose veins. Varicose veins may be primary, that is, without involvement of deep veins, or secondary, resulting from obstruction of deep veins. A reflux of a venous blood results in venous stasis. Venous reflux, also known as venous insufficiency, is a condition that occurs when the veins in the legs have difficulty properly circulating blood back to the heart. Normally, the veins have one-way valves that prevent blood from flowing backward, ensuring that it moves in the right direction towards the heart. However, when these valves become weakened or damaged, they may fail to close properly. This leads to blood flowing backward and pooling in the veins, especially in the lower legs. Superficial veins in the lower extremities become dilated and tortuous in response to backward or retrograde blood flow and increased venous pressure. If only the superficial veins are affected, the person may have no symptoms but may be troubled by their appearances. Primary varicose veins are unilateral or bilateral dilation and elongation of saphenous veins. Usually, the deeper veins are normal. In primary varicose veins, as the condition progresses, because of hydrostatic pressure and vein weakness, the vein walls become distended with asymmetrical dilation, and weak vein walls allow the vein wall ring to enlarge, so the leaflets no longer fit together properly. That is called incompetent. Dilation of the vein prevents the wall cusps from meeting. This results in increased back pressure, which is passed into the next lower segment of the vein. Incompetent vein walls allow backward blood flow, particularly when the patient is standing. This results in increased venous pressure and further venous distension. The combination of vein dilation and wall incompetence produce the varicosity. High pressure in the superficial veins can be caused by vein wall dysfunction in the deep veins or perforator veins, that is, veins that perforate the deep fascia of muscles to connect the superficial veins to the deep veins. Secondary varicose veins result from obstruction of deep veins, telangiectasias. Also called the spiral veins, are dilated superficial capillaries, arterioles, and venous. They may be cosmetically unattractive, but they do not pose a threat to circulation. Varicosities may occur elsewhere in the body when flow or pressure is abnormally high. What are the clinical manifestations? Discomfort from varicose veins varies among people. It tends to be worse after episodes of superficial vein thrombosis. Symptoms affect women more often than men. Symptoms may include dull legs, muscle cramps, increased muscle fatigue in the lower legs, ankle edema, and a feeling of heaviness of the legs. Restless or tired legs, fatigue, and nocturnal leg cramps may occur. Nocturnal leg cramps are common. The most common symptoms include a heavy aching feeling or pain after prolonged standing or sitting. Walking or limb elevation relieves pain. Some patients feel pressure or an itchy, burning, tingling, throbbing, or cramp-like leg sensation. When deep venous obstruction results in varicose veins, the patient may develop the signs and symptoms of chronic venous insufficiency. They are edema, pain, pigmentation, and ulcerations. Susceptibility to injury and infection is increased, thus increasing the risk for ulcerations. Disfigurement due to discolored, tortuous leg veins, easy leg fatigue, cramps in leg, heavy feeling, increased pain during menstruation, nocturnal muscle cramps. These are the symptoms that occur when deep venous obstruction results in varicose veins. Now, we will see the assessment and diagnostic findings. Superficial varicose veins often can be diagnosed by physical assessment. Diagnosis tests for varicose veins include the duplex ultrasound scan, which documents the anatomic site of reflex and provides a quantitative measure of the severity of valvular reflex. These scans are typically performed in a reverse Trendelenburg position or with the patient standing. Doppler ultrasound and duplex imaging can detect accurately and rapidly the presence or absence of venous reflex in deep or superficial veins. Ascending and descending venography is an invasive technique that can also demonstrate venous occlusion and patterns of collateral flow. Venography is not routinely performed to evaluate for valvular reflex. However, when it is used, it involves injecting a radiopaque contrast agent into the leg veins so that the vein anatomy can be visualized by X-ray studies during various leg movements. CT venography can be helpful, especially if the pelvic venous structures are involved. Photoplethysmography is a non-invasive technique to observe venous flow hemodynamics by noting changes in the blood content of the skin, used to detect incompetence in valves located inside the vein, and used to detect blood volume changes in the microvascular blood of tissue. Venous outflow and reflex plethysmography are able to detect deep venous occlusion. How to treat varicose veins? Conservative treatment involves rest with limb elevation, graduated compression stockings, leg strengthening exercise such as walking, and encouraging weight loss if appropriate, and avoiding activities that cause venous stasis by obstructing venous flow. Several natural and synthetic venoactive agents have been used to treat varicose veins and advanced chronic venous disease. Venoactive drugs work by stimulating release of chemicals within the vein walls to strengthen the circulation and reduce inflammation and edema. Therapeutic benefits of venoactive drugs include pain relief, reduced edema, and decreased leg cramping and restless legs. These drugs include micronized purified flavonoid fraction rutosides and ruscus. Surgery may be considered for ulceration, bleeding, and cosmetic purpose in selected patients if patency of a deep vein is ensured. The most common treatment options for venous insufficiency and varicose veins are surgical ligation and stripping, microphlebectomy, thermal ablation with radiofrequency and laser therapy, and foam sclerotherapy. What is ligation and stripping? Surgery for symptomatic varicose veins requires that the deep veins be patent and functional. The saphenous vein is ligated high in the groin where the saphenous vein meets the femoral vein. In addition, the vein may be removed. After the vein is ligated, an incision is made 2 to 3 cm below the knee and a metal or plastic wire is passed the full length of the vein to the point of ligation. The wire is then withdrawn, pulling the vein as it is removed. Pressure and elevation minimize bleeding during surgery. If there are superficial varicose veins that are close to the surface, a microphlebectomy may be performed. This procedure involves removal of a superficial varicosity using anywhere from 1 to 20 small incisions. There can be extensive bruising and a risk of infection with this procedure. Next is thermal ablation. Thermal ablation is a non-surgical approach using thermal energy. Radiofrequency ablation uses an electrical contact inside the vein. As the device is withdrawn, the vein is sealed. Laser ablation uses a laser fiber tube that seals the vein. Laser therapy eliminates the small veins under the skin. Next is sclerotherapy. Sclerotherapy involves injection of an irritating chemical into a vein to produce localized phlebitis and fibrosis, thereby obliterating the lumen of the vein. This treatment may be performed alone for small varicosities or may follow vein ablation, ligation, or stripping. How can a person prevent varicose veins? The person should avoid activities that cause venous stasis, such as wearing socks that are too tight unto the top or that leave marks on the skin, crossing the legs at the thighs, and sitting or standing for long periods. Changing position frequently, elevating the legs 3 to 6 inches higher than heart level when they are tired, and getting up to walk for several minutes of every hour promotes circulation. The patient is encouraged to walk 30 minutes each day if there are no contraindications. Walking up the stairs rather than using the elevator or escalator is helpful, and swimming is good exercise. Graduated compression stockings, especially knee-high stockings, are useful. The patient who is overweight should be encouraged to begin a weight reduction plan. What are the complications of varicose veins? Superficial venous thrombosis is the most frequent complication of varicose veins. It may occur spontaneously or after trauma, surgery, or pregnancy. Rare complications include rupture of the varicose veins resulting in external bleeding and skin ulcerations.